Hi, this is Alicia Bright. We're talking about ostomies and a little bit of a review of surgery, specifically as it applies to people with GI surgery. So, the most common indications for ostomy is colon cancer. Other possibilities are inflammatory bowel disease, which is why we are talking about it right now. We just discussed ulcerative colitis and Crohn's disease. And with ulcerative colitis, sometimes people end up with ostomies. Crohn's disease, while ostomies have been used in the past, they're really trying to avoid them at this point, especially for younger people, because it wouldn't it might rest the bowel for a while in the lower part of the intestine, but the upper intestine would still be affected. Another reason for ostomies is trauma, particularly penetrating trauma. But it could happen if somebody was in a car accident and they had a bowel rupture, for instance. The colon is traumatized. They might end up with a colostomy for a while. Or if someone has, of course, a penetrating trauma, a gunshot wound or a knife wound. If the intestine is damaged, they might put an ostomy in for a period of time in order to rest that other part of the gut and let it heal. So just the incidence of cancer, the most common area to develop colon cancer is in the sigmoid colon. The rectum is the next most common place. You don't really have to know these details. Ascending colon is probably the next most common place. The cecum, the transverse colon, and the descending colon are the least common places. But you can see that a tumor might arise in any point of the large intestine. Therefore, surgery might occur. Ostomy surgery might happen in various places. So, starting from the left and moving towards the right, this is where the ostomy would be placed for a problem with the ascending colon. The descending colon, you can see it's on the opposite side, where the colostomy might be placed. An ileostomy would be an ostomy that it ends at the end of the ileum. The end of the ileum is brought to the surface of the abdomen, and the colon, or the large intestine, is bypassed completely in that case. A sigmoid colostomy, of course, is down in the sigmoid part of the colon. Transverse, you can see it would be up at the top. In fact, a double-barreled colostomy, I've got a picture about that in a minute. A double-barreled colostomy would have a proximal loop and a distal loop, both brought to the surface, and I'll tell you why in a minute. Just as an aside, this ileostomy here, there would be an ostomy at the end of the small intestine, and so a stoma would be usually over on the right side of the body. This idea of a double-barreled colostomy, what happens is that they bring a loop of the intestine out of the abdomen, and they snip it in half, and they end up with two ostomies in one area. The one of them would be functional, would have fecal contents coming through it. The proximal point, of course, would have intestinal effluent or stool coming out. The other side is just brought to the surface and left there. It might have a little bit of mucus drainage, but of course, that part of the colon won't be working at this point. That part of the colon just goes from that colostomy point to the rectum without anything going through it. It just rests. Of course, it is made of mucosa, so there is some mucus that's secreted and that's inside that part of the intestine, but usually they'll do this double-barreled colostomy to rest the distal portion of the colon. So the problem would be in that portion, and they would take a double-barrel colostomy. They'd rest that portion of the colon for a while, and then they'll come back 6 to 18 months later and reconnect or reanastomose the intestine together tuck it back into the belly, and hopefully have a normal functioning in a colon. So this is a temporary colostomy. This is what they do when they think they'll be able to reconnect the colon and have it work well. You may remember this from lab, but you probably didn't actually see it on a real person. You may have seen it in a real person in clinical. Hopefully you'll be able to see that at some point. But these are pictures of actual ostomies, actual stomas rather. It's made of mucus. These are well-healed stomas, and they've shrunk down a bit, and it looks a little bit like lips because it is intestinal mucosa. You can see the device. Remember when you measured the ostomy device? You can see that on the right. The man's holding this measurement tool over the ostomy. And on the left, you can see this person has the whole ostomy device over them. Remember, when you've got that ostomy device, there's the sticky part that sticks to the skin. We might use some special ostomy paste to adhere it closely to the stoma so that the stool comes straight out into the bag and doesn't touch any part of the skin. And then there's the bag, which usually kind of zip locks onto the ostomy device itself. Now remember, the bag will be changed when it's about 1/3 full. I'm not changed. The bag will be emptied when it's about 1/3 full, but we don't change it very frequently. We only change it if we need to. The ostomy device, on the other hand, the thing that's actually stuck to the patient, that'll stay there for 3 to 5 days or until it starts to come loose. If it starts to come loose, we need to remove it, clean the skin, and carefully reapply it. But the bag just gets emptied whenever it's about 1/3 full. So, what's the function of the large intestine? Do you remember? Main function is reabsorption of water and electrolytes. So, what do you think you're going to have problems with if you have a colostomy? If you think about it, somebody who has lost their whole colon will be way more prone to dehydration and electrolyte disturbances than someone who has only lost part of their colon. So if you have somebody with a colostomy in the distal portion of the colon, you might have pretty functional a colon and pretty formed stool. If the colostomy, however, happens in the proximal part of the colon, or even in an ileostomy, you won't have that kind of reabsorption of water. So the stool that comes out is going to be a lot more liquid, and you have a lot more chance to lose electrolytes as well. So anytime you have surgery on the gut, anytime, it could be a colostomy, or maybe they just went in and they did surgery, they just took out part of the colon. They're not going to do a colostomy if they can possibly avoid it. Maybe they'll go in and they'll snip out part of the colon because it's so diseased with inflammation from ulcerative colitis, or maybe they have tumor, or maybe they got hit with a shotgun and that part of the intestine got damaged. So they'll open up the tummy, they'll snip out the part of the intestine and reanastomose the two ends of the intestine, sew them back together. Anytime you manipulate the gut at all, it stops moving. It stops the peristalsis, the normal peristalsis that keeps things moving through it. So you'd probably see some nausea and vomiting. You'd see some abdominal distension. You'd see hiccups, possibly. And there's something called a postoperative ileus. This results from any kind of handling of the intestine. And this is kind of a normal physiologic thing that happens. There'll be decreased motility, but it should resolve in 3 to 5 days. It should resolve pretty quickly. If it doesn't, then it's considered a complication of surgery if it goes on longer than 3 to 5 days. So how do we manage anybody with tummy surgery? Abdominal distension that happens with tummy surgery is really uncomfortable. What happens is the gut's trying to start moving again, and so there are some intestinal bacteria that function in the gut and create gas, and this will continue to the bacteria continues to do their bacteria thing and make gas happen, but uh, the body isn't moving the gas out the way it should. This results in distension and feelings of bloatedness, and it's actually can be quite painful. And I'll tell you what, morphine doesn't work for this. So we're going to be managing our patients' post-operative pain, but honestly, if they're having gas pains, you can't medicate them out of it. And the only thing that medication will do is make it easier for them to get up and move around, which is what will actually fix the problem. The cut will respond to morphine. The gas, they're going to have to get up and get moving. So, early and frequent ambulation, that's when you start seeing people kind of walking up and down the hall, pulling their IV bottles with them, their IV poles. They've got one hand on the IV pole and they got a very determined and sometimes a little bit desperate look on their face, and they're walking around and around and around the nurse's station, up and down the halls. Those are the folks with postoperative ileus, and they're trying to walk because they know that that will stimulate peristalsis, that'll get the gas moving, and that's one of the reasons why, we as nurses, we go into the room and we say, "Hi, how are you doing? I know you had intestinal surgery yesterday. Are you passing gas?" So it's like, "Hi, nice to meet you. Do you have a fart today?" Anyway, that's what we do. We get real familiar with our patients. We need to encourage them to pass that gas because that's what's going to get it out of their system. They're going to be more comfortable afterwards. So it's not necessarily, the most pleasant smelling thing, but it's got to happen. Putting them on their right side can help because intestinal contents will drop down the A transverse colon into the descending colon, so gravity can help us out a little bit. Biscadil is a stool softener. We might give them stool softeners to help stimulate peristalsis and help them actually pass stool. But really, getting them moving, making sure they're hydrated, that's what's really going to help. Just to review, anybody with abdominal surgery is going to need to splint that in order to take deep breaths and cough. And of course, it's important to get them deep coughing. So, a question for you. Speaking of nutrition, if you did a teaching with somebody with inflammatory bowel disease about dietary modifications, what kind of choices would tell you the teaching was effective? A. Baked cod, sweet potato, and canned pears. B. Barbecued brisket, coleslaw, baked bean, and angel food cake. C. Fried shrimp with cocktail sauce, corn on the cob, and a fruit roll-up. Or D. A turkey burger with cheese on a whole wheat bun, french fries, and an orange. So there's lots of good nutrition to choose from there. Veggies and protein and carbohydrate and stuff. Okay, the angel food cake is a little bit, indulgent, but let's look at this from a perspective of somebody who needs a low-fat, high-carb diet, but enough protein so that they can heal from an inflammatory process. Let's start at the bottom and work our way up. A turkey burger with cheese. Turkey's great. Whole wheat bun, that's fine. French fries and cheese are kind of greasy. The orange would be great, but I'm going to nix that one because of the fat. Okay, fried shrimp with cocktail sauce. Fried shrimp, there you go. There's the fat again. Corn on the cob. Actually, corn is one of those things that can be a little hard to digest for some folks. The fruit roll-up seems kind of benign, but we're nixing that one because of the fried shrimp and the corn on the cob. Barbecued brisket, coleslaw, baked beans, and angel food cake. Well, that sounds kind of yummy, but the coleslaw, that raw cabbage, that's going to be hard for people to digest. A lot of fiber. Fiber is great for preventing colon cancer, but if you have an irritable bowel already, if you've got irritation there, a lot of roughage can actually slow transit times and create more inflammation. So you want not to have too much fiber in somebody's diet. So baked cod, baked sweet potato, And canned pears provide some protein, provide some carbohydrate. It's a very low-fat diet, and those pears, uh, canned means cooked basically, and so they're going to be a lot easier to digest even than raw pears. So your answer here is A. And I hope that that was helpful discussion about post-bowel surgery and anti-inflammatory nutrition. And we'll talk about rheumatoid arthritis next.